Hello, my name is Christine Pate. I'm a clinical microbiologist by training, and I've spent the bulk of my career in the acute care setting. I've been an infection preventionist for over 10 years now, with certification in infection prevention and control and epidemiology. I also have a master's in public health and community health sciences and EPI. And currently, I'm a regional infection prevention consultant with the Hectone Institute of Medicine and an Illinois Department of Public Health grantee. In this presentation, we'll review the core structure of the infection prevention and control program within the long-term care setting. I have no relevant financial interests or relationships to disclose. And so the objectives for this presentation include describing the role of the infection preventionist or the IP in managing the infection prevention program, implementing standard and recommended best practices into the daily workflow of the IP, and also advancing internal organizational knowledge and understanding of key concepts and principles of the infection prevention and control practice. The contents within this presentation will include background, characteristics, and challenges in the long-term care setting, regulatory requirements and guidance, the infection prevention and program structure, the role of the IP, and also infection prevention program activities. So the daily workflow of the IP. Starting first with some background, the U.S. population age 65 to 85 is increasing rapidly. It's estimated that the population 85 years and older is expected to double by the year 2030. So with the aging of the U.S. population, those numbers of residents within the long-term care setting will increase. In 2018, an estimated 918,700 residents lived in residential care. And the acuity of the population served within that long-term care environment continues to grow, increasing the risk of healthcare-associated infections or HAIs. 61% of residents needed assistance with 3 or more activities of daily living. So with that reflection, currently there's considerable overlap and diversity in the long-term care population served, right? Care may be chronic care management provided to individuals not able to manage independently in the community. And these residents are often there for long stays, right? They're long-term care residents. And there's also that subgroup of short-term rehab or short-term residents that require rehab services. So what's driving the expanded diversity is that subpopulation. Again, that includes that post-acute care patients that are discharged to long-term care who receive skilled nursing services, where in the past, these patients would have remained hospitalized. Of note as well is that infections are the leading reasons or reason for hospital transfer to long-term care. For example, your IV antibiotic therapies. And pneumonia has been shown to be the leading cause of death for resident infections. So this created an important challenge for preventing infections as long-term care continues to manage the increasing acuity of residents, especially as the rapidly growing subpopulation of post-acute care residents increases. Facilities must balance residents' psychosocial needs with infection prevention guidelines to provide a safe environment while maintaining quality of life. So as a resident, facilities also provide social and group activities, right? And these activities are important for promoting good physical and mental health. They may also increase, unfortunately, communicable disease exposures and transmission. increasing the risk for person-to-person transmission or exposure even to contaminated surfaces and shared equipment within those environments. The medical complexity of residents has increased with the presence of invasive devices, and then poor hand hygiene of those residents that are more mobile, which have led to an increased need for infection surveillance in these settings. Often there's residents that have cognitive deficits that may complicate compliance with basic hand hygiene and or personal hygiene, like fecal and urinary incontinence and mobility and also cough reflex. There's multi-drug resistant organisms as well that are increasingly important cause of colonization, infections, and outbreaks in long-term care facilities. So the challenge here, how do we balance resident psychosocial needs with infection prevention guidelines to provide a safe environment while maintaining quality of care in life for our residents and patients within these settings? Let's take a look at regulations and guidelines. Long-term care facilities are covered by federal and state regulations. Regulatory requirements play an important role in infection prevention and control programs. The Nursing Home Reform Act, or OBRA, of 1987 mandated that long-term care facilities have an infection prevention and control program within the facility. CMS regulations also address the need for a comprehensive IPC program that includes surveillance methods for preventing the spread of infections like isolation precautions or your transmission-based precautions. Employee health protocols like immunizations, hand hygiene practices, and even appropriate handling of linens. OSHA. Adherence of infection control guidelines for long-term care is an OSHA priority. Because long-term care is an employer of healthcare workers, it must comply with federal and or state OSHA regulations, and often state regulations can be a bit stricter than the OSHA regulations depending on what state you live. For infection control, those regulations deal primarily with exposure to bloodborne pathogens like HIV, hepatitis B and C, and also TB exposures. So regulations are adopted and implemented into standard guidelines and best practices. They go pretty much hand in hand. And your states have the statutory requirements also for long-term care that may vary widely, again, depending on which state in which you live. CMS has conditions of participation. IDPH, or the Illinois Department of Public Health, has its own guidance, emergency orders, and also permanent and temporary rules. Again, there's OSHA. You have the CDC with its reporting requirements through the NHSN database for surveillance reporting. The CDC also provides guidelines for long-term care personnel, for instance, the COVID-19 guidance. And then we have voluntary accreditation standards and metrics like the Joint Commission, which requires a written infection control plan based on assessment of risk, established priorities, goals, and strategies, and also evaluation of those interventions. So let's look now closely at the program structure of the infection prevention and control program. I wanted to start first with definition of what a program is, more so for the novice IP, but definitely for the group as a whole, right? For those that are new in the role of infection prevention, on the cusp of the pandemic, during the pandemic, or post COVID-19 pandemic, it became a bit confusing of the role of the IP and also the program as a whole more comprehensively. Um, so it was seen more often as assigned task and list of responsibilities versus a structured framework in which to operate within a program. So again, let's start first with the definition of what a program is. So the term program is fairly generic, but it generally connotes a totality of an organized structure or a structured effort to provide a specific set of services or interventions for a specific target audience. Health programs tend to provide educational services and have a prevention focus and delivers services that are not direct services. So the primary focus in terms of an infection prevention and control program is to provide a structured framework, for preventing and controlling communicable disease in healthcare. It involves constant action at all levels of the healthcare system. So the IP is not alone in this, and that it's everyone's responsibility within that setting to carry out infection prevention and control practices. So the program functions to protect residents or patients, staff, visitors, and others, again, in that environment, to develop and recommend policies and procedures, to obtain and manage critical data and information through surveillance, to intervene directly, to prevent infections and interrupt transmission of diseases, and to educate and train staff, residents, patients, and non-caregivers like family members or visitors. So these are generally, in looking at the infection prevention and control essential program domains, these are components that are generally drawn, again, from regulatory requirements and current long-term care practices. So looking at antimicrobial stewardship, for example, CMS requires long-term care facilities to implement an antimicrobial stewardship program, including protocols, monitoring, procedures, reporting systems for incidents and corrective action within the facility's infection prevention and control program. It should also include education of providers that are prescribing, as well as other staff like nurses and patients as well. Water management. So the water delivery system is essential. It's an essential component of the environment of care in healthcare facilities. Waterborne contamination creates a risk for direct and or indirect transmission of pathogens. So it should be a system within the infection prevention and control program that has oversight and monitoring. The infection preventionist needs to maintain a high level of awareness for infectious agents that may cause waterborne infectious diseases in the population that they serve. And the CDC has a really great toolkit, guidelines, and recommendations for developing your water management program. That includes reducing Legionella and the spread of other waterborne pathogens within your building. There's linen management. So there should be policies and procedures for managing linens, which includes transporting and holding areas of both clean and soiled linens, storage, right, to avoid recontamination of clean linens. Laundry areas, clean and dirty areas should be separated. There should be negative air pressure on the clean side and compliance with state and national temperature requirements for washers and dryers. The infection prevention and control program should have policies specific and competencies for staff education, for safe handling of laundry, PPE use, hand hygiene in those areas, and also cleaning. So some key management functions of the Infection Prevention and Control Program. Again, this is a program, so there is management administratively with regard to oversight and organization of those activities within the program. So there's planning, both operational and strategic. So using data that's collected within the IP workflow as evidence-driven outcomes, right, to inform planning processes. Goals and defined objectives should be written within your infection prevention program plan, which we'll talk a little bit more about a little bit later in the presentation. Policies and procedures should be implemented and reviewed annually and or as needed. Quality assurance and process improvement, communication and feedback to staff, resource management, reporting, and also defining the role of the IP. So that job description is part of that management function as a reference point for the IP to review periodically, just to manage the scope of the responsibilities within the workflow, or even to update new responsibilities that may be implemented within that workflow. So policies and procedures of the Infection Prevention and Control Program. Here we have listed some general and some disease specific. This is not a comprehensive list, but as you can see, we have hand hygiene, transmission-based precautions and PPE use, environmental services, linen management, immunizations, occupational exposures, those disease ones, TB, C. diff, MDROs, and also the COVID-19 plan, which is not a policy or a procedure, it is a plan, but nonetheless is informative information on the purpose and procedures with regard to response activities and infection prevention and control measures that should be implemented within your facility in response to COVID-19. So the IP is not alone, right? Leadership support is a must and is necessary to carry out the organizational operations of the Infection Prevention and Control Program. There is the vital support also of the Governing Infection Control Committee. So the Infection Control Committee, that's the central decision-making body for the Infection Prevention and Control Program. It provides oversight of program activities, and it should be an interdisciplinary team. The members should include, of course, the IP, administration, and or an executive leader. Your nursing representatives, so your directors of nursing and your unit managers, your nurse unit managers, your medical director or chair, environmental services, food services or dietary, your maintenance or engineers representative, laundry services, clinical services, so your ancillary services like dialysis and your therapies, pharmacy, whether on site or a pharmacy consultant that has a relationship with your facility, the same with laboratory and other external consultants. So think about your water management program and that subject matter expert consultant that you have working with you to help manage your water sampling. Include that individual as well on your committee for routine reporting of lab samples for water testing and such. So the committee is a major involvement for the IP, as you can see. The Infection Control Committee gives administrative power to the program. It is the official route for informing your administration of infection control problems and accomplishments, such as outbreaks and new regulations and guidelines, policies and procedures, and routine data sharing outcomes. The infection preventionist should consult, report on other institutional committees as well, so that other leaders and administrators are aware of current infection control program activities or potential risks. So occupational health within the long-term care environment has a role that significantly overlaps with the infection control program. All employees should have a baseline health assessment, right? And current immunizations as recommended for healthcare workers by the Advisory Committee on Immunization, or ACIP. Refusals should be documented. So assessment should address the following immunizations as you see here listed on the slide. All employees should be offered influenza vaccine annually, and for injection safety and a respiratory protection program, which requires fit testing and also bloodborne pathogen exposure, which should include protocols for managing exposures and illnesses, are all OSHA requirements. So let's just stop here for a minute for a pop question. I just want to take a minute to give you all an opportunity to read the question and over the 3 listed response options. So here we have, does your infection prevention and control program have a program plan? So that would be your infection control program plan. First option, yes. It is reviewed and updated annually and as needed if there is a significant change, like a pandemic, by our facility infection prevention and control committee. Second option, yes, but our corporate directors handle the infection prevention and control program plan review. And then the last response option, I don't know, I'm not sure what that is. Okay, so now let's look at the next slide, which goes over the components of the program plan for your infection prevention and control program. Okay, so every infection control program should develop a well-defined written plan outlining the organizational philosophy regarding infection prevention and control. The plan should take into account the goals, mission statement, and assessment of the program. It should include a statement of authority, the surveillance plan, and the plan should include review of patient demographics, including geographic locations and the patients served. The scope of responsibilities for actions to be taken to accomplish the goal should also be included in this plan. And data should always drive your plan. So the infection control program plan is sometimes also referred to as the quality improvement infection control plan, and it should be reviewed and revised annually. Each revision should include defining objectives of the goals with due dates and responsible parties. So again, you have the statement of purpose and authority, your mission goals, your population served. It should inform your program activities, share surveillance plans, include your risk assessment, which we'll talk about next on the next slide, and also provide that QAPI intervention, again, with due dates and responsible parties. So this is really, your plan is your blueprint, so to speak, for the program, right? It helps to organize and also prioritize activities for a working year, right? So you look back on outcomes and activities from the previous year to then inform and update your plan for the upcoming year, as does the risk assessment. So the risk assessment, we'll look here at the risk assessment. It prioritizes as well and documents risk for evaluation and action planning, and it serves as the starting point of a well-developed infection prevention plan. This is specifically an assessment for your infection prevention and control program. So it's not to be mistaken for your facility risk assessment. Again, this is for your infection prevention and control program. So it entails evaluation of the facility's data and activities, again, from the previous year. So typically you would perform your risk assessment for your program end of December, early January. You're looking back at outcomes from activities of the previous year or the end of that year. It identifies risk for acquiring and transmitting infections. So it has a scoring system where you identify high volume, high risk, and problem-prone activities. The probability of an event occurring, impact, severity, and current systems. And then it calculates a risk score. The threshold is, I believe, 8. So any score above 8 is an area of opportunity for which you can prioritize as a target intervention for your upcoming year. It assists in focusing surveillance and other program activities, and it set priorities for appropriate resource allocation and obtaining support from key stakeholders. And again, it is a component of your IPC program plan. There's also other risk assessments used within the infection prevention and control program, in addition to your infection control risk assessment described here. So you have your TB risk assessment, which I'm sure most, if not all of you, are familiar with that. And it is also required to be performed annually. And then you have your ICRA as well, which is specific for construction projects or renovations in your buildings. The ICRA should be performed with your contractor prior to beginning of a construction project. So together, the IP and other stakeholders relevant to this process will sit with the contractor and review the ICRA and score and rate hazards and metrics that should be in place before the start of a project. For instance, HEPA filters that are needed to control dust during construction, or barriers that are needed in place, again, for dust, controlling dust or redirecting traffic flow from that work area, as well as transport of removable materials and so on and so forth. So now let's transition and look at the infection preventionist, right? The role of the IP. So the IP is responsible for implementing, monitoring, and evaluating the infection control program. The IP should have sufficient infection control knowledge base to carry out responsibilities appropriately, and the IP should have the administrative support, again, needed to effectively direct the infection prevention and control program. They cannot go it alone. The infection preventionist role is that of a leader, a subject matter expert, so you become a consultant internally and also perhaps externally for your facility. a collaborator, as you'll collaborate across departments and with staff across your facility. A facilitator, as you will often lead meetings and discussions and projects. So being an effective communicator is key. For certain, a champion for resident or patient safety, a researcher, a critical thinker, influential, and of course, a model for change. Professional competencies for the IP. So having knowledge of microbiology, of different organisms and pathogens, the infectious disease process, epidemiology, antimicrobials, asepsis and aseptic technique, disinfection, sterilization, resident or patient care practices, education. So think about the competencies and in-servicing of staff. So these teaching skills will definitely come into hand with that. Program administration. Again, you're managing a program, not just, a list of responsibilities and tasks, but you're managing a program. And so keeping that organized is key. And then having knowledge of regulations, whether federal, state, or local regulation. So maintaining a knowledge base is really key for the IP to carry out the responsibilities appropriately. And during your tenure, you'll find that you become a lifelong learner, which I love. So we'll pause one more time for another pop question. Which activities do you dedicate most of your time to? So looking at the list below, try to pick at least 3 and think about maybe if you want to rate them from, top to bottom, one being an area you would or activity you would spend the most time in, and then 2 and 3 accordingly. Okay, now let's look at the next slide. So responsibilities of the infection preventionist. You can see here the pie chart lower right that surveillance. Most activity is dedicated to surveillance within the IP day-to-day workflow, right? And that may not come as a surprise to any of us. When we think about, again, just that daily review of information and data, right? We're looking at labs, at our isolation list, at all of our residents or patients with devices, antimicrobial use, so on and so forth. So that analysis and then any investigation that may be warranted from that surveillance and analysis will also pull us into that direction. So let's take a closer look at our workflow. Routine activities, right? There's, again, surveillance and reporting, identification, investigation, and control of outbreaks, performance monitoring and process improvement. So hand hygiene is a big one when it comes to performance monitoring, as well as PPE. So with hand hygiene, routine hand hygiene, of course, should be encouraged. We want to think about the WHO 5 moments of hand hygiene and not just that entry and exit of resident or patient rooms, but we want to think about before we touch a patient, afterwards, after touching a patient or resident, as well as the same for touching body fluids or equipment. And then compliance should be, with that should be routinely monitored again. Supplies should be readily available for hand hygiene and also conveniently and strategically located throughout your facility. There should be written infection prevention and control policies for hand hygiene that are available and current and based on evidence based guidelines, and also job-specific training and education to all healthcare personnel for all tasks. So what does hand hygiene look like for someone who's part of the EVS team versus someone who's in laundry or in dietary, right? We want to provide that job-specific education. Transmission-based precautions and PPE, regular education or in-servicing with these practices should also be developed to reinforce understanding and compliance. There's implementation of policies and procedures. So think about, again, training, in-servicing, and competencies, and also developing programs. That's a way that the IP will implement these policies and procedures internally, is through providing these activities and services within the organization. Employee health activities, antimicrobial stewardship, and then there's also oversight and partnerships. So EVS, IP has some oversight for environmental cleaning and disinfection. That's a partnership, a very important partnership with the IP in the EVS team, as well as environment of care. So again, think about construction and also your water management program. Antimicrobial stewardship. The ICP, or Infection Prevention and Control Program, should include the implementation of the core elements of antimicrobial stewardship, or AMS. Antimicrobial stewardship is the effort to measure and improve how antibiotics are prescribed and used in your facility and within your patient or resident population. Improving prescribing is critical to effectively treat patients and infections and combat antibiotic resistance. There's core elements provided by the Centers for Disease Control and Prevention, or the CDC, for antimicrobial stewardship. That includes leadership. So leadership should demonstrate support and commitment of antibiotic use in your facility. Accountability is one that should identify leadership. So a physician or a nurse that would be responsible for promoting and overseeing those activities. There should be action with implementation of at least one policy or practice in your facility to improve antibiotic use. So these are the things we talk about when you have your ICARs, your infection control assessments, or your regulatory surveys that should be evidence of an antimicrobial stewardship program. There's tracking. You want to monitor at least one process measure of antibiotic use and at least one outcome in your facility. Reporting, provide regular feedback. You want to give that feedback on antibiotic use and resistance to prescribing clinicians, nursing, and any other relevant staff. Include your pharmacy consultant as well. Education. You want to provide resources, again, to clinicians, nursing, and also your residents or your patients and their families as well, as they can influence these decisions about antibiotic resistance and opportunities for improving use. So identifying a lead or co-lead who is accountable for the antimicrobial stewardship program and management of the outcomes for these activities is critical to the success of the program and also to the policies and procedures. And an example, a priority example of leadership would include giving time, right? Dedicated time by your administration and resources to manage the program and to conduct these daily activities. Let's switch and talk a bit about surveillance as part of the workflow, the daily workflow of the infection preventionist or the IP. So surveillance is an essential component of an effective infection control program. Surveillance plays a critical role in identifying outbreaks, pandemics, emerging infectious diseases, MDROs, and also bioterrorist events. It determines the baseline and endemic rates of occurrence of a disease or event, right? So it gives you a baseline of what you're seeing in your facility with regard to different organisms, what you see most often, less likely. That way you have a threshold, and you're able to determine, when counts are above or below the threshold, whether or not an intervention is warranted. Surveillance includes design in accordance with, it should include design, in accordance with current recommended practices and should be consistent with defined elements. So following guidelines and metrics like NHSN, the National Health and Safety Network through the CDC, and also your state guidelines like IDPH. It should include observing practices, right? And so our observations of hand hygiene and device utilization and sterilization practices are all part of surveillance activities. Some additional activities and methods that we use. So what does surveillance actually look like within our workflow and methods that we use daily? That would entail review of admissions and discharge and transfer data, right? So we're looking at these admissions, discharge, transfer data. We're looking through resident and patients charts. We're reviewing those. We're looking at labs. We're rounding on the units in our facilities. These are all surveillance activities in which we're collecting data. Elements monitored. We're looking at devices. So again, central line utilization and maintenance, as well as indwelling urinary catheters, antimicrobial stewardship. There's activities there around resistance, indication, and so on. Hand hygiene compliance. So we're collecting observation data for compliance rates. We're using internally rates and externally ratios with NHSN reporting. And we're also looking at data trends. So we're looking at incidence and prevalence. We're using standard criteria and definitions. So think again about NHSN and also McGear. And there's the reporting piece of surveillance. After collecting and analyzing data, we're then reporting out data externally and internally. We want to make sure we're sharing that information internally as well. And then lastly, we'll look at quality assurance and process improvement within the workflow of the IP or QAPI. So the IP plays a critical role in improving the quality of healthcare. Infection prevention and QAPI activities can complement each other. Patient safety practices such as continuous quality improvement and root cause analysis can augment infection control programs. So identifying timely and relevant improvement opportunities, using and measuring data to support process improvement, also leading and implementing process improvement projects and assembling teams and champions, and then monitoring and evaluating those outcomes. So this is a continuous cycle, right, of monitoring. So integration with the organization's QAPI program is essential to identify opportunities relevant to the infection prevention program. Here are some activities that are or may be familiar to the IP. The IP collects a wealth of data consistently that is definition and guideline driven. So the IP routinely uses data to monitor outcomes, right? This is what we do routinely, and we identify timely and relevant improvement activities and opportunities, excuse me. So the IP should take leadership roles on the QAPI team with things like CAUTI and CLABSI bundles and prevention activities and those outcomes, auditing of hand hygiene and PPE use and EVS cleaning, unit rounds again and observations, educational in-servicing and training, and then that survey preparedness and readiness. So practice activities are goal directed, as you can see, with these activities listed, and the IP certainly plays an important role in all of these activities listed within their daily workflow. And so it would be a great lead in terms of leadership for the QAPI team. So that will conclude the presentation for the Infection Prevention and Control Program Structure as an operational framework for your Infection Prevention and Control Program. I've included here a list of references and works cited throughout the presentation. I appreciate your time and engagement and listening through this presentation, and I hope that you are able to take much away from it and use internally within your own workflow, in your organization, and within your infection prevention and control program. Thank you so much.